In this session, we are going to be looking at the topic Alagille Syndrome. Hi, I'm Sharon. I'm working as an assistant professor at College of Nursing. The following are the objectives that we'll be addressing in this session. Alagille syndrome (AS) is an autosomal dominant disorder, OMIM 118450. Here, OMIM stands for Online Mendelian Inheritance in Man. It is associated with abnormalities of the liver, heart, skeleton, eye, and kidneys and has a characteristic facial appearance. This disorder was first discovered in 1969 by Alagille et al. Other names are Alagille-Watson syndrome as well as arteriohepatic dysplasia. Alagille syndrome and genetics. It occurs in 1 per 100,000 live births. The gene defect in 60 to 75% of the cases is an intragenic 94% mutation in the JAG1 gene located on chromosome 20p12 or deletion of the entire gene, which occurs in 6%. JAG1 mutations are found in approximately one-third of patients presenting with only one or two clinical features of Alagille syndrome. Mutations in the gene encoding NOTCH2 have been described as well. JAG1 gene encodes a cell surface ligand JAG1 for the Notch receptor. Notch signaling pathways play an important role in embryological development and in adult oncogenesis. Alagille syndrome is related essentially to a defect of vasculogenesis. Let's look at the genetic testing for Alagille syndrome. For a suspected diagnosis Alagille syndrome, if a particular patient meets a classic criteria, we can go ahead for family testing. If a confident clinical diagnosis is made, confirm the diagnosis and further assessment to be done, monitor medical problems, surveillance and genetic counseling. Again, if the diagnosis is confirmed, offer to the relatives, assessment is necessary, genetic counseling and genetic testing. In case the patient does not meet the classic criteria but has some features of Alagille syndrome, then again family testing can be anticipated and there is need to test for JAG1. If negative, consider testing for NOTCH2. Again, if negative, consider alternative diagnosis or Alagille syndrome phenocopy or other Alagille syndrome gene and consider patient or family for research. Whereas, if while testing JAG1 turns out to be positive or again Notch testing turns out to be positive and the diagnosis is confirmed, go ahead for the previous plan, that is further assessment, monitor medical problems, surveillance and genetic counseling, and to the relatives, assessment, genetic counseling and genetic testing can be done. Let's address the clinical features of Alagille syndrome. Hepatic, duct paucity, where there is absence or marked decrease in the number of interlobular bile ducts, cold status, neonatal hepatitis, fibrosis, cirrhosis, portal hypertension, liver failure, hepatocellular carcinoma, and nodular hematoma. It is a benign mass of disorganized tissue native to a particular anatomical location. In cardiac, murmur, pulmonic valvular stenosis, teratology of Fallot, pulmonary atresia, truncus arteriosus, VSD complex, VSD, ASD, anomalous venous return. Vascular, there can be peripheral pulmonic stenosis, pulmonic outflow stenosis, coarctation, patent ductus arteriosus, renal artery stenosis, middle aorta syndrome, Moyamoya syndrome, which refers to a vascular disorder in which the carotid artery in the skull becomes blocked or narrowed, reducing blood flow to the brain, and CNS malformation. Skeletal, there can be butterfly vertebrae, shortened interpedicular distance, shortened phalanges, short stature, spina bifida occulta, fusion of adjacent vertebrae, absent 12th rib, shortened distal ulna and radius, clubbing, pathologic fractures, osteopenia, and rickets. In ocular, three things can be addressed together, that is referred to as the Axenfeld-Rieger syndrome, here given separately as posterior embryotoxon, Axenfeld anomaly, and Rieger anomaly. All these three refers to an autosomal dominant genetic condition characterized by anterior segment dysgenesis and systemic anomalies. In 1920, Axenfeld characterized the anomaly which bears his name when he described posterior embryotoxon and iris strands adherent to the anteriorly displayed Schwab's line. Posterior embryotoxon is a clinical and histological term referring to displacement of Schwab's line anterior to the limbus in the cornea. Rieger described patients with congenital iris abnormalities including iris hypoplasia, keratoconus, and polyporia, now thereby referred to as Rieger anomaly, in 1935. It has other associated findings such as dental, facial, bone defects including maxillary hypoplasia, umbilical abnormalities, and pituitary involvement. Further symptoms in the ocular are shallow anterior chamber, cataracts, strabismus, exotropia, ectopic pupil, optic disc drusen, iris stromal hypoplasia, band keratopathy, glaucoma, microcornea, keratoconus, congenital macular dystrophy, anomalous optic disc, fundic hypopigmentation, pigmentary retinopathy, and night blindness. Facial or cranial features show in pediatric there can be particular facies and in adult also particular facies, sinus abnormalities, chronic sinusitis, thin cortical bones, deafness, large ears, high-pitched voice and macros, carefully. In renal, there can be neonatal renal insufficiency, adult renal failure, solitary kidney, ectopic kidney, horseshoe kidney, bifid pelvis, duplicated ureter, small kidney, cystic and multicystic kidney, dysplastic kidney, infantile renal tubular acidosis, juvenile nephronorthosis, lipidosis, tubulointerstitial nephropathy, and interstitial fibrosis. In CNS, there can be intracranial, epidural, subdural, subarachnoid, and intraparenchymal bleeding, stroke, vascular malformation, mental retardation, developmental delay, school dysfunction, abnormal visual, auditory, and somatosensory work potentials. In cutaneous, there can be jaundice, xanthomata, which is deposition of yellowish cholesterol-rich material that can appear anywhere in the body in various disease states, thickened lignified hands and feet. Growth disorders, where there can be failure to thrive, fat soluble vitamin deficiency, protein calorie malnutrition, and short stature. In pancreas, there can be exocrine insufficiency, diabetes mellitus, and pancreatic fibrosis. Other features can be tracheal and bronchial stenosis, jejunal atresia, ileal atresia, malrotation, microcolon otitis media, and extrahepatic malignancies. The peculiar facies in the face includes broad forehead, deep-set eyes, upslanting palpebral fissures, prominent ears, straight nose with bulbous tip, and pointed chin, giving the face a triangular appearance. The classic criteria for Alagille syndrome includes full status, typically presenting as jaundice in the neonatal period, often with pale stools, facies, broad forehead, deep-set eyes, straight nose with a bulbous tip, pointed chin, giving the face a characteristic triangular appearance, and a prominent or bat ears. Heart disease, most often peripheral pulmonary artery stenosis and 30% structural defects such as AST, BST, tetralogy of Fallot or pulmonary atresia. Vertebral anomalies such as characteristic butterfly vertebrae, a radiological appearance due to incomplete fusion of the anterior arches of the vertebrae, with other reported anomalies being hemivertebrae, fusion of the adjacent vertebrae, and spina bifida oculta. Finally, posterior embryotoxon, which is a prominent shwabbly ring at the junction of the cornea and the iris, also seen in 8% to 15% of the normal subjects. Diagnostic tests that can be done include liver function tests, including D-glutamyl-transferase, serum cholesterol and triglycerides, bile acids, complete blood cell count, coagulation studies, and liver ultrasound. Liver biopsy may also be done depending on the clinical scenario. A cardiology evaluation including echo, renal ultrasound and renal function tests, anteroposterior spine radiograph, ophthalmic evaluation, nutritional assessment including fat, salt and vitamins, and yes, the most important, genetic testing. All this will help us to conclude if the particular patient has Alagille syndrome. In management, specific to hepatic includes for pruritus, chlorhydric agents such as ursodeoxycholic acid and cholestyramine, rifampin or naloxone. Biliary diversion may be very helpful and can be useful before liver transplantation. Finally, liver transplantation, where the success depends on coexisting cardiac and renal impairment, 5-year survival of up to 80% and results in improvement in liver function and growth in 90% of the cases. For live donors from the biological relatives, genetic testing to rule out gene carrier status should be undertaken in which the mutation is known. Contact sports should be avoided if splenomegaly is present, and strictly no alcohol consumption. Other management includes management of cardiac and renal malformation. This will help in following the practice appropriate to the particular problems that each patient has, and similarly for vascular accidents as well. And it is very unlikely that vertebral anomalies will require any intervention, and the same applies to most ophthalmic features seen as well in Alagille syndrome. The following are the references for this particular topic. Thank you for your patient listening.